सर संजीव सर आप हो ना सर?
Yes, I am there.
Okay, sir, we are starting then.
Okay.
So I welcome everyone. I am Dr. Swapnil. I am working as associate consultant at Apollo Hospital Critical Care Department. Today's topic is heart transplant myths, dilemmas, and intensive care issues. So it is 41st educational series on platform of Apollo Mumbai Critical Care Learning Network. I request all of students to put any queries if they're in chat box, and I request take advantage of today's topic. It might be a bit of longer than every day, and we will try to make it interactive as possible as. So welcome all of you. I welcome Dr. Gunadhar Padi. He is a senior consultant intensivist at Apollo Hospital, Navi Mumbai. I welcome Dr. Akhilesh Tandekar, sir. He is a consultant intensivist in critical care department. I welcome Dr. Sanjeev Jadhav. He is chief cardiac surgeon and heart transplant surgeon at Apollo Hospital, Navi Mumbai. I welcome Dr. Saurav Tiwari. He is a senior consultant in cardiac anesthesiology department, and I welcome all of students, and I am very thankful to this amazing network to create this educational series for benefit of everyone. So I hand over to Dr. Gunadhar sir from here.
Yeah, thank you, Swapnil. Thank you for the nice the introductory session. And I think today we have a very interesting session, and this is basically something very much different from the routine critical care, and it's something called as the super specialty services in intensive care medicine. So transplant program, and currently we are running cardiac, heart and lung transplant program in our institute. So just to have the discussion further, today we'll be discussing regarding the what is a basically the ideal transplant program should consist of, and we have all our eminent faculties and panelists today. The chief cardiac surgeon, Dr. Sanjeev Jadhav sir, and Saurabh, the chief cardiac the anesthesiologist. So we'll take with few interesting means presentations, and followed by discussions among the panelists. And so I'll just share the slides, and I request all the DNB trainees, critical care trainees, to put their questions in the chat box, so that at the end of the talk, we'll be taking the questions one by one. So I welcome you all on the behalf of the Apollo Hospital, Navi Mumbai Critical Care Department. And I'll be starting the talk with the basic presentations of history of the cardiac transplant. So as we all of us know, the history begins with the experimental heart transplant long back, and followed by the clinical heart transplant program in for the first of its kind in the South Africa, where in the left side, the right side, you can say the first cardiac transplant donor, Dennis Darwell, and the recipient Louis. So this is the first program which is started in the world, basically the first cardiac transplant operation, and followed by our Indian scenarios, where we are Organ Transplant Act in India came in 1994, and after that the program has started its journey, and with all the eminent cardiac surgeons across the India. And so basically, what is the indications for adult heart transplant in different scenarios? So if you go by the AHA and American Cardiology Association, so basically these are the different indication which is given, like refractory cardiogenic shock, a person who is suffering from end stage heart disease after the maximization of the medications and all the intervention which is possible, and thus he is symptomatically not getting better with peak VO2 max less than 10 ml per kg per minute, or if the person falls into NIVHA class 3 or class 4 despite all the optimum medical or resynchronization therapy. Of course, recurrent LV arrhythmias despite AICD, antiarrhythmic therapy, or catheter-based ablation, and all the end-stage congenital heart failure with no evidence of pulmonary hypertension and refractory angina. So if you see for the European Society recommendation, basically all patients with severe symptoms, episodes of fluid retentions, and one or more hospitalization in the last 6 months with low ejection fraction and severe cardiac dysfunction, they are the candidate for the actual adult heart transplant. So with this, I would like to know the surgeon's perspective in this. So whom should we ideally refer such type of patients, and what is the ideal indications in the Indian scenarios? Because there are a lot of myths involved. So Dr. Sanjeev sir, if you are there, sir, you can highlight it from your perspective, sir.
So basically, any patient whose heart function is poor, around 10 to 15%, 20%, and extremely symptomatic. These two criteria are very important to refer patient for heart transplant. And then the clauses come whether that patient is appropriate for heart transplant or not. So any patient who is symptomatic with poor heart function comes in a bracket of heart transplant. Then if the age is appropriate, we don't accept age more than 65 years of age. Worldwide, there are many centers who accept age around 70 years, but we don't accept more than 65 years of age for heart transplant. So there are age, multiple other factors who automatically factors like severe systemic infections or viral infections like HIV, HBsAg infections, associated multi-organ failure, drug addicts, and poor financial health may not, they automatically become a relative indications, contraindications for the heart transplant. So basically a patient with poor heart function and extremely symptomatic state with who is not improving with maximal medical therapy or appropriate surgical therapy. Like a patient who needs a bypass surgery for ischemic heart dysfunction should require bypass surgery. Patient with valvular heart disease should go for a heart valve replacement or repair. And even after that, if patient is symptomatic, then patient should be referred for heart transplant.
Yes, sir. Thank you, sir. Thank you. So with this, so what are the different pre-heart transplant evaluation usually needed? So there are these four basic steps, which is very, very important. Of course, apart from that, there are a lot of other preparations and the team effort is required. But these are the different scoring system usually to be followed for a cardiac transplant patients. And most important is the exercise capacity assessment with VO2 max. If the patient is symptomatic or if the patient is having NOH a grade 2 or grade 3 and he's having an end stage the symptoms of heart failure and he comes to us. So these are the different scoring system normally being followed. So one is called the heart failure survival score and second is called the settle heart failure model. And of course, the newer model is impact scoring system. So going further, this heart failure scoring system, the VO2 max is one of the important integral part of this scoring system. So normally, if this is called the maximum volume of oxygen consumption, if it is less than 14 ml per kg per minute, then this patient is having a very high risk of mortality and he should benefit from the heart transplant. And of course, there is a category where it is more than 14 ml per kg per minute. Obviously, this is falls into the low risk. But it is not only the prediction. There are a lot of other factors which is there in the heart failure scoring systems, like something called as the resting heart rate, the arrhythmias in the last few weeks, or if the ejection fraction which is taken into consideration, whether the patient is having other comorbidity like diabetes or hypertension, so or the significant other comorbidity, these are also being taken into account. So with this, the heart failure scoring system says that if the score is more, obviously the chances of 1 year survival is more. And if the score is less, those patients belong to the very severe category. Like if the score is less than 7.2, obviously the 1 year survival rate gradually goes down to 35%. And the similar prediction score is Seattle scoring system. The almost the same model, the prediction model is same. And the most important thing is which patients the transplant is a contraindications. So let's hear from our intensive care perspective, Dr. Achilles, and then we'll go to Sanjeev sir. So what is the most ideal contraindication, particularly in a Indian scenario where ideally the transplant should not be considered or it is not going to benefit?
So yeah, thank you, Dr. Gunadhar, for this question. So basically, we in Indian subcontinent we have financial constraints as a major hurdle that we face from day-to-day life. Our population is very, financially, they are not sound. So that is one part. That isn't, but that cannot be a contraindication. But if the patient is stable uh, and he is able to do his day-to-day activities with maximal therapy, and he doesn't have repeated admissions or hospitalization for heart failure, and if the patient is evaluated in heart failure clinic that this patient is likely to be benefited with maximal medical therapy, so these are the patients, probably we can wait and continue with the patients where, the patients have already received medical therapy, but these patients sometimes can be benefited with some destination therapy, like, LVAD therapies and all that. Suitable donor is not possible. Sorry, patient has been listed, but we have bridging therapies which are already placed, like destination therapies, like LVAD, which the patient is being benefited dramatically. So we can wait in these patients and continue with the destination therapy. There are patients who are, continuing their good quality of life even with the destination therapies for 10 years, 15 years. And the survival also has also improved in these patients. So these are the patients probably the transplantation can be avoided if they are benefited with these devices. And some of the patients who can be benefited with bypass surgeries or even with a valve replacement, they can be given a chance to undergo these procedures, and these patients can be benefited. There are few patients who are very compliant with the treatment, a borderline kind of patients, uh, and those patients who are elderly, age above 75 years or so. I mean, there is no definition, clear-cut definition. But if the patient is elderly and who is not able to withstand surgical intervention, and the patient has been repeatedly hospitalized, and a refusal from the patient is also one of the contraindications for the therapy for cardiac transplantation. I would like to hear from Dr. Sanjeev Jadhav in this regard as well.
Yes, sir.
Yeah, the main contraindication is age. Higher the age, more than 70 years is a textbook contraindication. Secondly, patient with associated major organ dysfunction, like severe kidney dysfunction or liver dysfunction or lung dysfunction. For heart transplant, we regularly evaluate lung in terms of pulmonary function test, transpulmonary gradient by right heart catheterization, and pulmonary vascular resistance. So any major organ dysfunction is automatic contraindication for heart transplant. Psychologically unstable patient, drug addictions, uh, alcohol addictions, poor financial support, severe systemic infections, metastatic malignancy is definitely contraindications for heart transplant. Squamous cell carcinoma of face with low metastatic potential are not contraindications for heart transplant. And any malignancy with more than 5 years of cure can become an indication for heart transplant. So diabetic patient is a very important factor in decision making for heart transplant. Many of these patients have diabetes, and diabetes is uh, not a per se contraindication, but diabetes with associated end organ dysfunction like diabetic retinopathy, severe diabetic retinopathy, or severe diabetic nephropathy are associated with relative contraindications for heart transplant.
Thank you, sir. Thank you for the elaborative discussion. So the another important point for every patient who is considered for the transplant is the pulmonary vascular resistance. And we know that if the patient is suffering from end-stage heart failure, so obviously the PVR in most of the cases is high. And sometimes when these patients are received a new heart from a donor, so the new heart sometimes takes times to get adjusted to the elevated pulmonary vascular resistance of the that particular patient. So usually they go into right ventricular failure. That is why the right ventricular failure is very sometimes common, and it is a challenge after the transplant. And we know that the normal PVR, which is measured in Woods unit, is less than 1.5. If it is high, more than 6 Woods unit, then sometimes it poses a absolute or relative contraindication for the transplant program. But it is a dynamic process. So there are many of the studies that shows that the PVR is sometimes reversible, like agents like milrinone, dobutamine, prostacyclin, inhaled nitric oxide, and sometimes with implantation of the left ventricular assist device, you can significantly bring down the PVR, and actually those patients sometimes do well. So this is a study which suggests actually there are 26 heart transplant with a fixed pulmonary hypertension of 5.1 plus minus 2.8 Woods unit. And they have shown that the perioperative mortality in such patients is in the range of 5%. And when they followed up this patient up to 3 years, sometimes the mortality also goes up to 85%, comparable to transplant without pulmonary hypertension. That is why this is very important that one should work up for the this pulmonary hypertension and measure it actually. So what is your take, sir, in this regard? So do you get any challenges during your surgery also if the lungs are stiff, or it is only a post-operative issues?
Now, during surgery also, when you are coming off bypass, they give a lot of trouble because this is a new heart, and usually denervated heart or a patient who has have preservation injury, right heart dysfunction is very common in a donated heart. So in this scenario with a right heart dysfunction with a high PVR can give you trouble while coming off bypass from the heart lung machine. And this will continue with a primary graft dysfunction, which is called PGD, primary graft dysfunction in immediate post-op period. So this is very important factor, primary graft dysfunction and pulmonary vascular resistance goes hand in hand during early post-op period. And I would say most of the patient, around 70 to 80% donated heart in post-operative period will have some kind of right ventricular dysfunction, which is usually managed with milrinone, nitric oxide, and pulmonary vasodilators. And over the period, it usually improves. We had many incidences in our heart transplant patient like this, and usually they improve over time.
Yes, sir. So I would like to hear from Dr. Saurabh. So what are the challenges in during the anesthesia when and what how the scenario is to be managed if the patient has significantly showing right ventricular dysfunction or high pulmonary artery pressures? Dr. Saurabh?
Yeah, so for taking any patient for heart transplant, we have to screen for the RV dysfunction, the factors, clinical factors, and while the management starts right from the while the selection of the donor, if the donor is screened properly and he fits into our criteria, we don't have issues for the RV dysfunction in the recipient. But in the recipient, we have to do the TOE to find the various parameters for RV dysfunction. And while coming off bypass, we see to it that we have got nitric oxide in the connected to the circuit as well as milrinone ready. which are the cornerstone for the treatment of RV dysfunction. And if we don't start it prophylactically, there is a lot of challenge, and the patient deteriorates very fast in the ICU period. We all have all this experience while managing this RV dysfunction, and the management has to be start from the previously only.
Yeah, absolutely. Thank you. So that nitric oxide, usually we continue up to almost 3 to 4 days in the post-operative period to tackle sometimes these high pulmonary pressures, and that to be started in the operation theater itself. Profile empirically, I think as a measure. So these are the different pre-transplant investigations which is normally required, and it almost covers a lot of all the spectrum of investigation which is actually required for that particular patient, starting from the serological test, different references, starting from all the routine investigations, infection screening, and all the cardiac workup in the form of 2D echo, your coronary angiography, right heart catheterization, carotid Doppler, and everything which is included. So here I'd like to know from Dr. Achilles. So like serological tests and sometimes the our immunological test, I can say the pre-operative immunological tests are sometimes very, very important, and that actually sometimes decide whether this patient is fit for the transplant or not. So so what is your take on this? Like panel reactive antibodies.
So yeah, as far as screening of the patient is concerned, apart from the routine investigation, it is very imperative to do panel reactive antibodies, and if these antibodies are present, these patients have high chance of rejection. Okay, and apart from this, RH compatibility matching is also very important. As far as the transplantation is concerned. For these panel reactive antibodies, I'm not able to remember the range and antibody titer. We need to see the titer at a particular titer. Sometimes, if the titer is in the acceptable range, we can go ahead with the transplantation. But I would
You
like to
want me
hear
to
from
add?
Dr. Sanjeev Jadhav. Yeah, Dr. Sanjeev Jadhav will be able to tell us better in this regard as far as the panel
Basically,
reactive antibodies is concerned and rejection process, how
panel
the
reactive
rejection can be avoided. Yeah.
panel reactive antibodies has two class 1 and class 2 antibodies. These are basically antibodies measured, which are antibodies against the antigens present in the society in that area. So these are class 1 and class 2 antibodies, and they are detected for a hyperacute rejection. So if a donated heart has got these antigens and these antibodies are present in the recipient, there is a hyperacute rejection that occurs. So basically, the measurement of panel reactive antibodies to avoid the hyperacute rejection in the immediate post-op period. And if panel reactive antibodies, it's a basically an bead assay, and if they come positive, then we do a single bead assays in these patients, and measure there is MFI values. If MFI values is less than 1,000, then we proceed for the transplant.
Yes, yes. So absolutely rightly told, sir. So in 1 or 2 patients also where the panel reactive antibody is inconclusive, we have measured this the second test, and that value is sometimes conclusive, and we can safely say that this patient at present is not fit. But obviously, we have to repeat the titer and see what are the values. So that is
So
what is.
do we target any tighter values, or even
Yes.
I mean, or we need to have absolute absence of these antibodies? What is your take on this, Dr.
Yeah, I think up to 20, I think the 20 units, I don't remember the unit exactly, but up to 20, I think it is acceptable. Or safe is less than 20, if I'm not wrong. The PRA value safe less than 20 is acceptable, I think. More than 20, you have to ideally, again, repeat it and see whether this patient is fit or
So,
not.
is there a possibility if the panel reactive antibodies are in an indeterminate state? Probably it is between 14 to 20 or something like that. So, what
No,
all precautions
as
would we
what
need to
Gunadhar is
take?
saying is, if the panel reactive antibodies are positive and the range is around less than 20, we take it around 15. But if less than 20, we still can go ahead and do the transplant. But chances of rejection very high. And if they are more than 20%, then the possibility in this patient that we should go for plasmapheresis in this patient and then take this patient for transplant. That would be a better idea to filtrate these antibodies and do the transplant.
Yes, yes,
DQ, the class 2 antigens DQ, DR, DB, these antigens, we do a single bid assay if they come as positive in class 2 antigen or even class 1.
yeah, yeah. So
We
yes, sir.
Apart from plasmapheresis, do we need to give any immunosuppression before taking the patient for the
That
transplantation?
that will be discussing. This management of immunosuppression is there in the last slide. We'll be discussing that. So after that, what is the more important thing is like vaccination, diet counseling, education by social workers, stopping of all the addictions, final resources and arrangement. Of course, this is sometimes the finances is a constraint for many of our patients. Of course, that is also a hassle for Indian scenario. And this is a typical vaccination schedule for a patient of heart transplant or lung transplant, which is written by our ID specialist, starting from the flu vaccine to the pneumococcal vaccination, the deworming course to be given. And ideally, the patient should be given vaccination and then to be taken up for the cardiac transplantation to avoid any kind of opportunistic infection. So, sir, any take on this, sir? Like usually, how many days we have to wait, or ideally after the vaccination schedule? Any take on from your side? Sir, you are on mute, sir.
sorry, we give these vaccinations on the day of admission for heart transplant evaluation because we don't know when this heart transplant will occur. So it is better to develop immunity against these viruses as early as possible. So on the day of admission we give, and so that whenever the heart transplant occurs, there will be an immunity against these viruses,
Right.
bacteria.
Yes, sir. Yes, sir. So the most important is the donor selection criteria, and I think the cardiac surgeons are the best person to comment on that. So along with the donor retrieval team, the most important role of them is like the donor selection criteria. So I just like to highlight certain few points regarding the donor selection, so that a good donor is selected for a appropriately size matching recipient.
You want me to talk?
Yes, sir. Yes, sir.
Uh, uh, the ideal donor should have a appropriate age. A young age donor is always preferred. It should be matched with body mass index, chest circumferences, and weight and height of the patient. Usually this is happened at 11th hour, so it is just an eyeballing of chest X-ray to match these donors. Secondly, donor should have ideal donor should have a normal heart function. There should not be any valvular disease or regurgitation, especially. Many of the donated heart would develop tricuspid regurgitation because of right ventricular dysfunction, which is expected due to organ preservation issues. And there should not be any coronary artery disease. So these are basic expected in like though we say that we need a younger donor, many a times we use extended criteria donor. Like if our recipient is old age, like 60 or 65 years, and he is in dire emergency to get heart, or he is extremely sick on the mechanical circulatory devices. In such situation, it becomes important to give him a heart as early as possible. In that situation, we give extended criteria donor heart, like patient who is little old, 60 years of age, ejection fraction is little less, 45, 50 years of age, for 45-50%. This is called extended criteria heart. And so it's a relative, but ideal donor should have a normal heart function, and should not have any infection, should not have any malignancy, uh, and should not have any viral markers. Should all viral markers should be negative.
Yeah,
Yeah.
and yeah, regarding the IBO compatibility, just this is not we don't actually do the RH the matching, but as a general rule, so any AB positive can donate the can receive the heart like a universal recipient, and O negative is a universal donor. So apart from that, if there is an incompatible transplant, so most of the times the problems are like hyperacute rejections in the form of platelet deposition, granulocyte activation, and thrombosis. So this is very important. So that is the reason the blood grouping is very important here actually. And with this, I think we'll go to the next this what are the different management for the donor like brain dead donor in that particular hospital. So any patient who is referred for refractory heart failure, first the recipient if he comes to the hospital, he should ideally be referred to a heart failure clinic. Reversible factors should be corrected. The medical therapy should be optimized. No significant comorbid conditions identified is very good. If the VO2 max is less than 12 ml per kg, if the heart failure survival score is less than 8.1, ideally we have to do a right heart catheterization. We have to measure the PVR, and the PVR should be less than 6 Woods unit for the absolute contraindication for the transplant. And then we list that patient for the transplant. And this is basically the elective listing. And this is basically the brain dead donor management in that particular hospital. So the very important is like the volume status. Normally we don't overload such patients because the fluid itself is detrimental. We have to correct the acidosis of the donor, correct hypoxemia, correct anemia, adjust the inotrope, and obtain the initial echo. So normally the good echo and good window is very important, particularly if the donor is more than 40 years, ideally angiography is required. To echo is required to rule out any structural abnormality in the donor like substantial left ventricular hypertrophy, valvular dysfunction, or congenital lesions. If the EF is less than 45%, usually it is not a good heart, but still we can go ahead with hormonal resuscitation and hemodynamic management and to meet the criteria. But if the EF is more than 45%, ideally it's a good heart, particularly the suitable candidates are good ejection fraction of 55 to 60%. Then those donors are the ideal donors. So apart from that, sir, any other points that you would like to highlight for the donor and recipient?
I think sometimes because of adrenal storm, many of the donors may behave with a little less heart function, or they may show a reduced contractibility on 2D echo when a team approaches the donor hospital. This time we give a injection thyroxine and see how this heart behaves. Many of this time after thyroxine, the heart ejection fraction or a quality of contraction improves, and in that situation we take that heart.
Okay. So that is why these hormonal resuscitations are very, very important. Normally, we give thyroxine. We start with vasopressin, which is the vasopressor of choice in brain dead donor. And also we give steroid supplementation like methylprednisolone 1.5 milligram per kg bolus. And of course, insulin infusion 1 unit per hour to minimum to keep the blood glucose level between 120 to 180 milligram per deciliter. So these are the 4 hormones or 4 supplementation to be given for resuscitation of the brain dead donor, and this improves the outcome in the recipient after the transplant. So these are different newer impact UNOS allocation criteria for heart transplant practice and outcomes, like the emergency listing. So something called as the now the new allocation system from the 6-tier system, now it has been changed to 3-tier system. One is status 1, status 2, and status 3. Any patient who is on VA ECMO and any patient who is having life-threatening ventricular arrhythmia with devices, he is the basically listed in the supra urgent list. And status 2 is patient who are on IABP, patient who are VTVF without mechanical support, or where the mechanical circulatory support devices are there, but due to the malfunction, the patient is sinking, or there is a single like percutaneous endovascular mechanical circulatory support devices. The status 3 patients are dischargeable LVAD for almost the patient who are on LVAD for, and they're doing well, but still it is served as a bridge to transplant. Patient with single inotrope with continuous monitoring who are in ICU. So these are the third priority. So that is why the JTCC gives priority to the supra urgent listing. And this is the pathophysiology of the transplanted heart. Like we know that there is a sympathetic and parasympathetic denervation. So the resting heart rate, normally the heart is more under the control of parasympathetic or vagus. So that is why after the heart get transplanted, the resting heart rate usually goes high. So that is why the transplanted heart shows a rapid resting heart rate. But the important point here is because of the sympathetic denervation. So what is something called as the heart cannot mount the stress response after the surgery to any stress response, either in the form of hypovolemia, either in the form of other stress response. So there is no mounting of chronotropic response. And sometimes we have to keep the heart rate on the higher side sometimes. And in this case, we usually start with postoperative isoprenaline drip to maintain the heart rate around 100 to 110 to maintain the normal physiology. So this is called the denervated heart and followed by the renervation. So normally it has been found that up to 5 years, sometimes the patient may take 10 years for the complete complete nervous system to get renervated for the heart. So that is the reason you find these are the physiological findings. Sometimes you may get double P waves in the ECG. Sometimes the vagal stimulation has no effect on the sinus and AV nodes. There is no reflex tachycardia in response to hypovolemia and hypotension. And indirect acting sympathomimetic agents actually have no effect, because here the directly acting sympathomimetic agents work, like norepinephrine, epinephrine, dopamine, or phenylephrine. So this is one of the important take-home messages. And sometimes the recipient atrial activity may be present, but it is not conducted. So that all these changes sometimes takes days to get settled down. You may find a lot of storms like VT, VF, or sometimes patient have significant bradycardia. So this is one of the important issues in the ICU, and just to show the ECG of a patient who is being transplanted, like double P waves sometimes may appear in such patients. So these are the ISHTL guidelines for the post-heart transplant monitoring. So almost all the invasive monitors are being covered, and what is important is like a good heart and lung transplant ICU care or particular segregated area, which is important for such patients. They cannot be kept in the routine ICU. And we are fortunate to have this heart and lung transplant ICU with us, where we keep such patients in the post-operative period. The hemodynamic management, the metabolic optimization, the infection control is very important. Respiratory management like ventilation are very important. So to go one by one, these are the different intensive care dilemmas. So hemodynamic instability, bleeding and volume status, hypertension, donor size mismatch leads to big heart syndrome, arrhythmias. There can be primary graft failure as told by sir. Like ABO incompatible transplantation sometimes are challenges, and we have to absolutely careful about the infection, rejection, and if the patient is having a allosensitization previously, like if the patient has a mismatch or ABO incompatible transplant. So allosensitization is very, very important. Like if the patient has a very high panel reactive antibodies, so how to allosensitize that particular patient and take him for the transplant. So I would like to hear from Saurabh. So most of these issues, they start itself in the OT and they continue in the post-operative period. So how do you tackle the hemodynamic instability, like pharmacological support and mechanical support? Dr. Saurabh.
Yeah. So we get a fair idea when the patient is taken in the operation theater. So what was the ischemia time? The most important is how good was the donor, how young was the heart, and what was the ischemia time. If the ischemia time is fairly managed by less than 4 hours, and we get the heart in the OT, most of the time we get the things are uneventful. But if there is an increase in the ischemia time and the donor heart is marginal with some problem, we expect some issues in the intra-op and the post-op period. Also, I would like to add that the donor part, we have to do a TOE examination, transesophageal echo examination, to see how the heart is. Like we get the echo, but we have to do the TOE to substantiate our results, to see if any ASD is there, any regional wall motion abnormality is there. And the surgeon also clinically examines the heart at the table itself. And when we come in, when the heart reaches the recipient, there is a very fine coordination between the donor team and the recipient team. Our recipient team is geared up. The patient, the recipient is already on the bypass, and the disease heart is explanted. And while coming off bypass, we keep all our important inotropes, inodilators, nitric oxide, and even the ECMO team is ready to tackle if any RV dysfunction is there. So most of the time, the inotropes which we use are adrenaline, isoprenaline, and inodilator we use milrinone, and even NORAD, as NORAD is there, but the prime is isoprenaline and adrenaline. And important is that we should always we have to put all the pacings cable also, RV and the AV pacing is there. It is always important that we have a ECMO team also available, that sometimes if this RV dysfunction is not being tackled with the nitric oxide and the inotropes, then we have to go to the ECMO also. And all these inotropes are continued in the post-op ICU team also, so that the same management is followed in the ICU. We try to use the minimum blood because we don't want any rejection. And also the immunosuppression protocol, the institutional protocol, we have to start like the basiliximab and the steroids. And then when we go to the ICU, we can elaborate on the immunosuppression, what we follow.
Yeah, thank you. Thank you, Saurabh. Thank you. So these are the different other issues like bleeding and the volume status. Sometimes there can be medical cause of bleeding which need to be tackled, like the platelet count, the INR, the other bleeding parameters, the fibrinogen need to be monitored if the patient is having a generalized use. And surgical cause, of course, is one of the challenges. Like sometimes the patient can have cardiac tamponade. Because of the cardiac tamponade, the patient can be hemodynamically unstable, and in that case, emergency re-exploration need to be done, and that has to be evaluated by both the ICU, anesthesiologist, and the surgical team. Surprisingly, many of the patient, in compared to hypertension, they show hypertension, and this can be because of the baroreceptor mediated reflex. Sometimes this patient can have renal injury in the intraoperative period itself, and because of drugs, because of the stress response to surgery, there can be catecholamine dysregulation, and it is a systemic inflammatory response syndrome. That is the reason. So sometimes this patient can paradoxically show hypertension also. So the immunosuppressive medications like tacrolimus sometimes can produce hypertension. And the most important thing is like donor size mismatching during the operative table, and which can also pose a threat in the post-operative period if there is, like sirs told, there is not inadequate donor to recipient size. So there is something called as big heart syndrome and small heart syndrome. Like if the heart is big, that can sometimes manifested as severe hypertension, tachycardia, and the patient ultimately go into hypertensive cardiac failure. If there is a small heart syndrome, the patient can have significant pulmonary because of this significant pulmonary vascular resistance. The donor heart, the recipient goes into your something called as the right ventricular failure. So these things need to be sorted out. And arrhythmias are, of course, very common, like SNO dysfunction is there. The ideal rate should be more than 90 as per IS-STL guidelines. High rates to be kept in the smaller patient. This is the most important part, like monitoring of the patient in the post-operative period. So I would like Dr. Achilles to stress upon this. Like on the left side, we have a cardiac output monitor which shows almost all the parameters, and the left side, like on the right side, you have a nitric oxide monitoring, and left side on there is a cardiac output monitor. So what are the important the monitoring tools, and what parameters are very important in the post-operative period of such cardiac transplant patient? Achilles.
Yeah, Thank you, Dr. Gunadhar. So it's very important that when patient comes in post-operative period, usually this patient is ventilated and he is sedated. Fluid management is one of the important parts. You know, we try to conserve fluid during intraoperative period also, and these patients also receive diuretics intraoperatively. So these patients they pass a lot of urine, but we need to see whether this patient needs fluid resuscitation. So fluid responsiveness is very, very important. Generally, we usually start with maintenance fluid, 60 to 80 ml per hour, but the fluid resuscitation is guided by different parameters like clinical parameters and the laboratory parameters. The clinical parameters will be depending on the heart rate, and we employ hemodynamic monitors. We usually have arterial line and pulmonary artery catheter also in place, and with which we can monitor the pulse pressure variation with arterial line. If the pulse pressure variation is more than 13%, this patient is likely to be fluid responsive. At the same time, we have pulmonary artery catheter and we see what is the pulmonary artery wedge pressure. And if the pulmonary artery wedge pressure is below 8, probably this patient is likely to be fluid responsive. So in this situation, we have to see the trend. A single value of any parameter is not, it has to be, seen as a trend. And at the same time, we have ABG, the lactate will also help us to guide whether the patient needs fluid resuscitation. Even base excess is also need to be monitored. We usually have hemodynamic monitor with which we can monitor stroke volume, cardiac output, and stroke volume variation and systemic vascular resistance. So these patients who come from operation theater, they have cold peripheries, cold extremities because of the strong AC. They usually have systemic vascular resistance on the higher side. Generally, we accept a systemic vascular resistance of 600 to 800, but if it is going beyond 800, milrinone or vasodilator will be very useful. We also monitor cardiac output and stroke volume. Generally, stroke volume has to be at least 45 to 50 ml per kg. And cardiac output and cardiac index is also monitored. Supranormal cardiac output and supranormal cardiac index is also not advisable because that is not acceptable. Because if we keep on chasing these values, we end up abusing with vasopressors or inotropes. So a cardiac output of around 4.5 to 5 liters and cardiac index of 3 to 3.2 liters is sufficient enough to give you a good idea that heart is moving well. And at the same time, we monitor, even with we have hemisphere monitor, which helps us to monitor pulmonary vascular resistance and pulmonary pressures are also monitored. If the pulmonary resistance is going high, we need to titrate the doses of nitric oxide, and milrin and also can be adjusted. Nitric oxide is, a perfect pulmonary vasodilator, whereas milrinone has both systemic effects and pulmonary effects. So when we try to increase milrinone, uh, there may be a systemic vasodilatation which may be detrimental. So conservative fluid strategy is very important. We should not, overzealously resuscitate patients with excessive fluid resuscitation because that will lead to flooding of the lungs, and when there is flooding of the lungs, there will be hypoxemia, and because of hypoxemia, these patients usually develop increased pulmonary vascular resistance, and ultimately it leads to overload on the right heart. And one of the common causes of failure is right-sided heart failure, which gets neglected. So that we need to monitor right ventricular function more frequently. So for that, it is very imperative that everyone uh, should be well versed doing 2D echocardiography. All the intensivists, the anesthetists who are handling the patient should be able to do a 2D echocardiograph and monitor the TAPSE score. The TAPSE score generally should be around 15 to 17. And if it is less than 15, probably this patient is likely to develop right heart failure. And all the measures should be advocated to reduce right ventricular pressures like reducing pulmonary vascular resistance, titrating with milrinone and nitric oxide, and at the same time the PEEP should be reduced and hypoxia should be corrected as far as possible. Oxygenation can be titrated to chase a saturation of around 92 to 94%. And if there is any acidosis, the acidosis needs to be corrected. We need to find out what is the cause of acidosis. Generally the causes of acidosis could be low cardiac output or low hemoglobin levels or low oxygenation.
Right. So this is something
Delivery to the tissues and try to optimize oxygenation and correct acidosis in these patients. So fluid resuscitation is one of the important parts. Second, the sedation can be continued for some time till the hemodynamics are settled. We should not be overzealous or too much and becomes anxious or patient has not come out of the anesthesia. The weaning failure can be a problem. So every emphasis should be there to give good analgesia and sedation to this patient. Analgo sedation is very important generally. Opioids are preferred and
I think your network is not
in these patients. And then fluid resuscitation, analgesia sedation, and good fluid resuscitation and monitoring of the cardiac function and volume status is the cornerstone of the treatment. And then if the patient is stable hemodynamically, next day patient can be extubated. There are centers who extubate the patient immediately, post surgery, maybe within 4 to 6 hours also. And there are centers where the patient comes extubated also. So it depends upon the center's experience, how well are they, with the management of the patient. If the team is tuned enough, the patient can come extubated as well. So all the while, when we are monitoring patients, the urine output monitoring is also very important. Generally, 1 to 2 ml per kg of urine output is accepted, and then perfusion parameters, serial lactate monitoring also very important in this patient. Frequent to D also very important in this patient.
So this is something called as the primary graft failure. So mostly in the early postoperative transplant cardiac failure without any identifiable immunological anatomical etiology, and sometimes in spite of the best possible efforts, sometimes the organ they failed. So this is called the primary graft failure, and the mortality is in the range of 20%. And early identification is very important in primary graft failure, and it should be treated. The another important aspect is
yeah, Dr. Gunadhar, I would like to add on immunosuppression. So basically,
we have
patients
that
receive
slide.
immunosuppression.
We have that slide. I'm coming to that.
Okay.
I'm coming to that. So the infection is the most important type. The infection is something called as very challenging. So any kind of infection is detrimental to such kind of patient because they are on immunosuppressant. So if you see, basically to classify the infection in the first month of post heart transplant patients, usually it is something called as the nosocomial infection. So whatever the hospital flora we have, so we have to suspect those kind of infection first and treat the patient as per that part. Like many of the patients, they sometimes develop the central line related bloodstream infection, so we have to remove the central line. Sometimes they develop the catheter associated urinary tract infection. Sometimes the post-surgical infections are very high. So it is all because of the nosocomial infection. So where the bacteria are resistant, you have to hit them hard, hit them first. And also the bacteriology classification, mostly they belongs to methicillin resistant Staphylococcus aureus. If you see in the bacterial infections, or vancomycin resistant enterococci, sometimes we get lot of times C. diff colitis or Clostridium difficile associated infections. And sometimes many of the reactivation of the viral infection like herpes simplex virus, like CMV virus. So those prophylaxis are very needed. Also, the pneumocystis is an infection which the prophylaxis is started in the day 5th of such patients. The fungal infections are also not very rare. Candida likely to be fluconazole resistant, and early aspergillus if the patient has some comorbid lung disease like previously, those can the source. And after the 1 to 6 months, of course, the nosocomial infection chances are gradually decreases. But what is more important here is the patient develops opportunistic infection because of the intense and prolonged immunosuppression. So all these reactivation of the latent infections are there in the period of 1 to 6 months, where bacterial infections like Mycobacterium tuberculosis, Listeria monocytogenes, Legionella, and Nocardia, these are the predominant infections. And you suspect some kind of reactivation of the viral infection in the form of BK virus, adenovirus, respiratory syncytial virus, CMV virus, Epstein-Barr virus, and other things. The fungal infections, of course, Aspergillosis, Cryptococcus, PCP infections is, of course, if the patient is not on prophylaxis, is very, very important and sometimes common. The parasitic infections, opportunistic infections are Toxoplasmosis, Strongyloidosis, sometimes Trypanosoma, which is we have not yet encountered, but these are not very rare. After the 6 months, usually as the dose of the immunosuppression gradually decreases, so the chances of infections are also gradually decreases slowly. And it is nothing but it is usually the community acquired bugs which causes the infection in such patient after the 6 months. So either it is a reactivation of the latent infection during the ongoing immunosuppressions. So particularly the community acquired infections, either in the form of community acquired your methicillin sensitive Staphylococcus aureus, or some kind of pneumococcal infections, or Legionella infections, or UTI, particularly in a patients, or it's like sometimes community acquired pneumonia, particularly with your H influenza or pneumococcus. All those things are very, very common. And rarer infections are the fungal infection here, and also the parasitic infection. The ISHTLT guidelines clear-cut shows that the perioperative antibiotic prophylaxis is actually not mandatory and not required. Only if you suspect infection in the donor, or the donor has a culture positive not with MDR, those cases, the perioperative antibiotic to be started and for the recipient. And of course, the prophylaxis regimen is normal like for other surgical your procedures, the 45 minutes to 1 hour before the surgery, and it should be continued in the post-operative period. Like if there is no evidence of infection, ideally for 2 to 3 doses should be enough. The surveillance the culture is mandatory routinely because these patients are on immunosuppression, and of course the prophylaxis in the form of pneumocystis, CMV, and the fungal infections are must in such patients. So these are the rejections. Basically, there are two types of rejections in heart transplant patients. One is called the antibody-mediated rejection and cell-mediated rejections. So the most important part is the cell-mediated rejection, which is very difficult to identify unless until you do an endomyocardial biopsy. So here I would like to hear from sir. So how do you tackle this challenge, sir? Like the cell-mediated rejection is one of the important challenges for the cardiologist and cardiac surgeons, and of course to all the team members. So Sanjeev sir, you are here. Okay, so this is basically diagnosed with routine endomyocardial biopsy at routine and regular intervals. And antibody-mediated rejection can also be possible, and there are a lot of antibody tests which are available to detect this antibody-mediated rejection. So if you classify the antibody-mediated rejection, it can be subclinical, preclinical, acute clinical, or it can be a chronic disease. So the chronic disease are something called as cardiac allograft vasculopathy. The patient can show signs of rejection after 2 to 3 years of the transplant. And this is in the form of primarily the vasculopathy, like intimal thickening of different blood vessels, like typical the atherosclerotic changes, which happens in the donor vasculature. So this is all about the rejection, and as all we know that the immunosuppression is one of the important protocol in such type of patients. So broadly, these are the different immunosuppressive agents, starting from the basilicilimab to the different types of agents like calcineurin inhibitors like cyclosporin, tacrolimus, anti-proliferative agents like argathaprin, mycophenolate mofetil, mTOR inhibitors like sirolimus and everolimus. So normally what we use. Now I would like to hear from Saurabh, because the immunosuppression protocol itself starts from the OT. Then it carries to the post-operative period. So what immunosuppressant usually you start during the intraoperative procedure, Dr. Saurabh?
Yeah. So in the OT, we starts with the steroid at the bypass also, and we give a fine and we use basiliximab also, and in the steroid 500 dose of methylprednisolone, and again in the bypass, and 500 we give, and basiliximab 20 milligram over period of 2 hours. It is started till as soon as the recipient is started, and the other part of the immunosuppression is carried in the ICU. After the second day, we add the tacrolimus, and that level has to be checked regularly, and it is between 9 to 13. And you can elaborate on the ICU part. So in the OT, we start with the steroids and the basiliximab, and in the ICU, we have to carry with MMF and the tacrolimus.
Yes, Akhilesh. Regarding immunosuppression.
Yeah, so generally, once the patient has received in the operation theater, we usually, a patient has already received basiliximab in the operation theater and salprednisolone. So we don't add any further steroids or any immunosuppressants immediately. But the next day, we reduce the steroid dose to 500 milligram BD, and then later on taper to 50 milligram BD, and then tablets is switched to tablets later on. The other immunosuppression that we give is tacrolimus, and we keep monitoring the tacrolimus level. And tacrolimus levels sometimes may be erratically low or erratically high. And the patient may be symptomatic even with low levels of tacrolimus and can present with like features like patient may be agitated, irritable, or some patients even can grow seizures. We had few patients where the tacrolimus level was low and still patient had seizures. So it has to be considered as a tacrolimus toxicity. So in that situation, if the tacrolimus is showing toxicity or inadequacy of the action, then we replace it with other immunosuppressants. Azathioprine can also be added, and we also add MMF, and we make sure that the immunosuppressant are given in time, because if the time durations are also altered, adequate immunosuppression may not be achieved. Monitoring of calcineurin inhibitors, like it is very difficult. Tacrolimus monitoring, tacrolimus levels are monitored, but there are centers where we can even monitor MMF levels and other therapeutic levels also. And then as far as further immunosuppression is concerned, patient usually undergoes endomyocardial biopsy. And if there are any signs of rejection, these immunosuppressants can be optimized. In case there is acute rejection, basiliximab dose can be again added. And some patients who develop hyperacute rejection, even plasmapheresis can be offered to take care of hyperacute rejection in these situations. This is all from my side.
So sometimes what we need to check is the level of the immunosuppressions by sending the different tests. Like in our center, sometimes we send this CD4, CD8 ratios and absolute CD4 values and CD8 values, because it is very important for the first few days of the immunosuppression. Once you start the immunosuppression, you find your CD4 level, CD8 levels and CD4, CD8 ratio, they usually goes down. And that is a good sign that your immunosuppressions are all working and the immunosuppressants are within the targeted range. And simultaneously, you have to measure the trough level and the level of the immunosuppressant. As you know, that tacrolimus is a broad spectrum, or it is one of the immunosuppressant agent, but sometimes there can be a lot of idiosyncratic reactions. So the adequacy of immunosuppressant, it can be both seen clinically as well as by your laboratory test by sending the CD4, CD8 levels that subsequently falls every 3 to 5 days. Normally for first 7 days or 10 days we send, so that the adequate immunosuppression levels are achieved. And of course, the corticosteroids are the broad spectrum immunosuppression, which can be continued up to almost for 5 years. And if there is any evidence of any rejection. But this all the other immunosuppressants, ideally it should be tapered and stopped over a period of 1 to 2 years, primarily for the 1 year, and the dose has to be reduced because they have a lot of side effects. So these are the immunosuppressant protocol. There is a very important trial which is called the Tic-Tac trial. So this shows that there is the prospective randomized trial of single drug versus dual drug immunosuppression in the heart transplant patient. So particularly in tacrolimus is showing a very good response compared to the tacrolimus with other immunosuppressant. So even if you see that some of your patient develop toxicity to mycophenolate or your other immunosuppressive agents, sometimes you can stop that immunosuppressive agent for quite a few days and only maintain the patients on tacrolimus. This is particularly studied in the heart transplant recipient. And these are the different modified immunosuppressive regimens which shows that this improves the survival in the heart transplant patient. And this is the test which I'm talking about, like the CD4 CD8 ratio, the CD3 ratio, the absolute CD4 percentage, the CD4 absolute count. So once we see that all the values, these are on the lower side. Normal values will be 1, 1, 1, 1, 5. Now after immunosuppression, you find that these values that goes on decreasing, and that signifies that your adequate suppression is being achieved for that particular patient. So this is the thing. And with this, almost we have covered almost all the aspect, not in detail, but we have almost covered most of the aspect of a cardiac transplant patient. And the outcome is the near-term outcomes. Of course, it is very good. The patient relieved of symptoms better. But only thing is that sometimes you have to monitor them. There are a lot of infections which is actually fatal. And this is one of the commonest cause of death in such patients. So this is the Apollo Navi Mumbai experience, and we can see that this is the first of our patient who got transplanted, and the story begins in 1st August 2021 in the early morning of a heavy rainy day, when this is the patient which got transplanted and successfully get discharged after some times with our team, and this is the first transplant patient in the ICU, and after he successfully discharged from the hospital, and this is our the first transplant celebration and with all the team members. And this is our subsequent transplant patients, the second cardiac transplant patients, the third and fourth in a row, and fifth and sixth transplants which are in the ICUs. And this is back-to-back transplant has been done by our cardiac team. And this is the story. The fifth heart transplant in a row, successfully going home and discharged.
The slides are not seen.
Sir,
Slides are not seen.
you are not
We are
able
able to see the slide. I'm able to see the slide.
I think, sir, the slides
You
are
have to
visible.
use a different screen. You can just scroll on your monitor. So on the other part, the screen is coming.
Yeah, I think the slides are visible.
Share your
Yes,
slides.
slides are visible.
Yes,
Slides are
absolutely. And this is the seventh transplant, the celebration program in the ward itself by all the team members, cardiologists, our cardiac surgeons, and intensivists. And here the follow-up of our patients. Swapnil is here. And with this, I would like to thanks all of them who have attended today's webinar. Thanks to Dr. Sanjeev sir. Thanks to Dr. Saurabh, Akhilesh, and all the delegates and participants, our DNB students, and all critical care fellows. And if any question is there, I think our team is happy to take it right now. Otherwise, we would like to close down the programs. I think there is only one question. Yes.
Yes, sir. I was supposed to read the query only.
Yeah, please, Swapnil.
Sir, basically, we have already explained this, but the one query is about HLA matching and compatibility is not required, or yes. But probably I will take this question as in supramajor, what do you call that, supra-urgent surgeries. So I request Dr. Jadhav to answer this question.
No, I didn't get it actually, Swapnil. What are you talking about?
Sir, regarding the RH compatibility test in a cardiac transplant. So is it mandatory like in the kidney transplant? RH histocompatibility, sir.
No, because heart transplant happens at the 11th hour and you don't have time for HLA cross matching as you do in liver or kidney. So it is usually a retrospective study. So we collect the blood samples from donor and bring it to the hospital where we usually cross match retrospectively. So you don't wait or stop your heart transplant for this thing for AB or RH compatibility. We usually do a biocompatibility and go ahead with the heart transplant.
So RH compatibility is not mandatory. Only the blood grouping cross matching is important, and as we have discussed, RH compatibility is only mandatory in I think the kidney transplant.
Yes.
Yes, Swapnil, over to you.
Yes, yes, sir. Sir, before closing, I request all of students to have tune on our YouTube channel and to check our new announcement that we are going to do in the near time. So we are going to conduct a nephrocritical care session that will be for 2 days, and I request all of students or who is interested in it who can join and participate the session, and will take the and please take the advantage of this educational series. And other than that, I would very we will be very pleased to welcome all of students and delegates to see in critical nephrocritical care event that will be conducted soon, and we are uploading the or the all the announcement regarding that. Thank you, sir. That's it.
Yeah. Sir, one question is actually from Dr. Badri, like in all your 7 patients, what were the indication, clinical profile and complications till now? So just in a nutshell, sir, if you can
Commonest indication was dilated cardiomyopathy. And complication wise, in immediate post-op, we 2 or 3 patients developed right heart failure, or I would say right heart dysfunction. And they had to really manage vigorously in early post-op period. Otherwise, most of the patients did very well.
Yes. And the follow-up is still ongoing. Most all of them are means the patients are doing good, sir, till now.
Yeah. Yes.
So any questions or any kind of like your interaction, if you like to do any of us, like you can reach to us. So sir, if you can share your mail ID, sir, I can later on share on the group, so that they can directly in touch with all our surgical team as well as to the intensive care team.
Sure. I'll share later on.
Yes, sir. Yes, sir.
Okay.
Or
So transplant is a
yes.
yeah, transplant is a teamwork, a coordinated approach, taking everyone together on same page and working, with an intention. Like if everyone is able to do his part well, and if everyone is on the same page, probably we will be able to get a good outcome. So, like teamwork is very very important, and follow up of these patients is also very very important. Follow up of this patient with the surgeons, anesthetists, and intensivists, and then coordinated discussions as far as the follow up is concerned. That is also very important as far as the outcome is concerned. So that was the basically our coordinated approach that has helped us to have 100% success in our heart transplant program. That is what I can say. Kudos to the team.
Yes, Swapnil, I think I will hand over this mic to you for the final conclusion.
Thank you, sir. So ultimately, I am very much thankful to our platform creation to this Apollo Hospital support, and special thanks to Dr. Sanjeev Jadhav, who came to uh, uh, ca- who came for as per our invitation and address the session of heart transplant, which is a bit of new and very interesting session, and it is a not routinely read or handled by all of us students in peripheral or maybe most of the leading hospitals in even if in first tier, second tier, three tier cities. So I'm again very much thankful to Dr. Sanjay Jadhav. I'm again very much thankful to Dr. Tiwari to participate the session and guide us. I again very much thankful to Dr. Gunadhar sir and Dr. Akhilesh sir, who are my mentors and once again, thank you very much to all of our students and all my seniors. I'm very happy to conclude today's session at this point of time. Thank you very much.
Yeah, thank you. Thank you.
Thank you, everyone. Thank you.
Thanks.